Again, thank you so much for the opportunity to discuss this topic. So the disclaimer is that I'm an adult EP and not a pediatric EP, but nonetheless, I'll do my best here discussing ventricular arrhythmias and congenital heart disease with a focus on tetralogy of Fallot. So in general, this is a spread of a whole bunch of different congenital heart disease and the incidence of ventricular tachyarrhythmias in this patient population. And like I said, we're going to focus on tetralogy of Fallot because it's one of the conditions where you actually have monomorphic VT and a pretty significant risk of sudden cardiac death compared to many other of the congenital heart disease population. And to be able to illustrate some important points of this condition, we'll go through a patient case. So this patient is actually one that I shared with Dr. Peter, and we actually managed her together. So she had tetralogy of Fallot, and she was referred for a defibrillator implant. She's had palpitations and ambulatory monitoring that shows non-sustained ventricular tachycardia, and she's had several surgeries at the age of 6 months, 3 years, 6 years, and 16 years. Very complex repairs, and the last two operative reports were not available to us. So her echocardiogram showed a left ventricular ejection fraction of 50%, and her right ventricle was moderately dilated. She had moderate RV dysfunction and 2 to 3 plus pulmonic valve regurgitation. When you look at her ECG, you can see this classic right bundle branch block morphology with significant fractionation within the QRS, as you can see in the precordium and in the inferior leads. And her question to me was, "Doc, I'm 42 years old. Do I need an ICD?" And so she was a very intelligent woman. She was actually a dental assistant. And so we went through all of the guidelines to discuss, okay, well, what do our major societies suggest? And so if you look here, tetralogy of Fallot with clinical VT or multiple risk factors gets a class 2A indication from most societies and class 2 from ERA. And it became important for us to discuss, okay, well, what are these multiple risk factors that they're talking about? And this is what they list: a previous palliative or aortopulmonary shunt, a QRS duration of greater than 180, QRS fragmentation, NSVT, inducible VT, a ventriculotomy incision, or atrial arrhythmias. And the truth of the matter is that our patient had multiple clinical risk factors for ventricular arrhythmia and tetralogy of Fallot. And so like with every patient, we have a discussion about the risks and benefits of defibrillator implant. And I said, hey, you have a lot of different risk factors. There are a lot of different items that make us want to implant an ICD. And she's like, really, I'm young, I really don't want one. And so I said, okay, well, how about your demographics? What about you, from a demographic standpoint, suggests that you should receive a defibrillator implant? And in the study, they looked at atrial and ventricular arrhythmias in patients who had repaired tetralogy of Fallot. And the truth of the matter is, if you look at the red graph here, around the 4th and 5th decade of life in patients who are able to survive that much, there is a second increase in the incidence of ventricular arrhythmias compared to the first 2 to 3 decades of life, but that there was also an association between the incident risk of ventricular arrhythmias and the number of cardiac surgeries that you've had. And she has had 4. And so based on that, we had a shared decision-making discussion, and we agreed to implant a defibrillator. She came back for follow-up 3 years later. She had palpitations. She was getting shocks from her defibrillator. She was started on amiodarone. She continued to have therapy from her defibrillator. At that point, her ejection fraction on the LV side had declined to about 45%, and her right ventricular function continued to deteriorate. And so there was a multidisciplinary team approach to discuss, okay, well, what's the next best course of action? Her pulmonic valve is now severely regurgitant. Her RV is dilated and dysfunctional. And so the thought was, let's go ahead with a reduced sternotomy and consider a pulmonic valve replacement, as well as surgical ablation for the isthmuses that we know are responsible for ventricular tachycardia in patients with tetralogy of Fallot. So this was her EKG that suggests a right ventricular inferoapical exit site of her ventricular tachycardia circuit. And before we proceed, these are the common isthmuses of ventricular tachycardia in patients with tetralogy of Fallot. And so isthmus 1 is between a ventriculotomy incision or patch and the tricuspid valve annulus. Isthmus 2 is between that and the pulmonic valve. Isthmus 3 is between a VSD patch and the pulmonic valve, and 4 between a VSD patch and the tricuspid valve annulus. And so in 2017, she underwent pulmonary artery plasty, RV muscle bundle resection, plasty of the free wall, pulmonic valve replacement, and then cryoablative lesions delivered from the VSD patch to the tricuspid valve annulus and from the VSD patch to the pulmonic valve annulus. She recovered well post-operatively, and then she came back in follow-up and she said, "Doc, I had a pulmonic valve replacement and I had an ablation for VT. I'm free of arrhythmias. Do I still need a defibrillator?" And it turns out that in patients who have had pulmonic valve replacement and a history of VT, that doing the pulmonic valve replacement really does not have a change on the incidence of recurrent ventricular tachyarrhythmias. Again, in patients who have had ventricular tachycardia requiring shocks, who then go on to develop pulmonic valve, who go on to receive pulmonic valve replacement, there was no survival advantage as far as freedom from recurrent arrhythmia related to pulmonic valve replacement. And so in summary, no clear benefit in the sudden cardiac death risk reduction or incident VT in patients with pulmonic valve replacement. However, there likely is a role for EP study in these patients for surgical guidance for possible isthmus ablation. So patients that are candidates for pulmonic valve replacement, there is some discussion about taking them to the EP lab and doing an EP study, or prior to percutaneous, particularly stented pulmonic valves, because the metallic struts of a pulmonic valve that's percutaneous can start physically and mechanically boxing you out of the ability to deliver ablation in some of the substrate in this patient population. So 5 years later, she came back. She had recurrent palpitations and device therapies. This was worsening during a COVID infection. She required more diuretics, and she was transiently suppressed on amiodarone, which had been discontinued after her recurrent open heart surgery. You look at her device diagnostics, and she had a very significant uptick in VT-VF. This was around the time that she had COVID, and then that continued to kind of settle down, but then had another uptick here in June of 2022. And so we agreed to proceed to the EP lab, and we had two main objectives. One objective was to demonstrate block along the previously delivered surgical ablation lines, but then also map her substrate and try to understand what the mechanism was of her recurrent arrhythmia. In the right panel here, we see an REO projection of her right ventricle. The tricuspid valve is here. The pulmonic valve is here. Everything in red suggests scar and low voltage. Everything in purple suggests healthy, robust voltage. And so by that token, you can appreciate that this island of red tissue is where her ventriculotomy incision was, and this connects all the way up to her pulmonic valve. This is a slightly different LAO view of the same surgical incision here on the anterior free wall of the right ventricle. These next two pictures demonstrate conduction time and conduction velocity in the same patient during sinus rhythm, and anything that has a white line running through it is a proposed line of block. And so it seems that there is a line of block from her ventriculotomy incision to her pulmonic valve, as well as from the tricuspid valve to the VSD patch. And so it really seems like the surgically delivered lines had continued block, but somehow she had ventricular arrhythmias. And so this was mapping in VT, and you can see here a circuit near the inferior portion of her ventriculotomy incision that kind of goes around in a circle, around this area of delayed conduction near the inferior margin of the ventriculotomy incision. And the truth is, we actually didn't have the entire cycle length of the VT in this region, suggesting the complex substrate in these patients of both endocardial and epicardial substrate. And the fact that she's had multiple prior surgeries obviously eliminated our ability to have an epicardial approach for her ablation. So we delivered ablation near the inferior margin in this area that appears to be an isthmus, and she did well for several months thereafter. She was free of recurrent VT. Now the problem, as we know with this patient population, is that they continue on, despite freedom from arrhythmias, to develop heart failure. She started developing further RV dysfunction and cardiac cirrhosis from the same. She actually had a transplant, but unfortunately that was really quite complicated. She developed kidney dysfunction, she was on dialysis, and ultimately, unfortunately, passed away. And so in summary, ventricular arrhythmias in adult congenital heart disease, but specifically in tetralogy of Fallot, it becomes important to understand what the mechanism of ventricular tachycardia is, to have some sort of an algorithm or a framework for risk stratification, whether that's the demographic information of the patient, considering the role of EP study prior to pulmonic valve replacement, whether surgical or percutaneous, triaging ICD implants, and then also understanding the role for catheter ablation in patients who have scar-related VT, but then also identifying ventricular tachycardia in this patient population as a marker for how well they're doing clinically. It's not always just the fact that they have electrical scar, that they have VT. Sometimes that's a marker for heart failure. Think of it as a symptom of heart failure and progressive disease of the right ventricle and so on. And so considering advanced therapies in this patient population when available. Thank you.
Questions, please.
I'd like to ask about the role of MRI. Do you have a role for detection of fibrosis in the RV or something like that?
Yeah, that's a great question. So in patients that don't have contraindications to MRIs, certainly I try to scan all of my patients prior to VT ablation because it'll really shorten our procedure time if we have an understanding of where the scar burden is. Now the difficulty is many of these patients already have defibrillators. And so even if you have an MRI compatible device, the amount of scatter artifact that you get from the ICD lead in the RV, because that's really where all of the substrate is, can make it difficult to interpret. And so in patients with ischemic cardiomyopathy, for instance, and a lot of substrate in the left ventricle that we see for ablation, even if they have an ICD lead, sometimes we're able to get decent images. But because the substrate here is in the RV and your lead is in the RV, the quality can be poor.
Can I ask you about the setting of unipolar map, voltage map, in these cases with different complex congenital anomalies, with the thickness of the LV, RV, if it's systematic or not? How do you manage this?
To understand the epicardial surface? Yeah, so I've kind of moved away from unipolar mapping and honestly have been focusing more on ablating, on targeting delayed conduction and targeting areas of isochronal crowding with the St. Jude system, as opposed to really spending time understand. Because if the epicardium is something I don't have access to, then sometimes just using those surrogates for conduction time has been our area of interest, both research and during procedures. So thank you.
Okay, I have one last question. There's something you said that resonated with me on a previous experience now. When a patient has extensive scarring in the RV and develops ventricular tachycardia, I had a similar condition where after ablation and terminating the VT, the patient goes into rapidly progressive right ventricular failure. Yeah. Do you have any experience or any similar conditions to this in your practice?
Yeah, I'm trying to think. I mean, I generally haven't seen kind of you terminate the VT and they rapidly decompensate. Yeah. But I really do believe that in many of these patients, the VT is a symptom of things, that things are decompensating. And so you get rid of the VT, but that doesn't change their clinical course because the substrate is just so severely abnormal and the RV is so dysfunctional that you just eliminated a symptom, but the underlying process is just still continuing in the background.
Thank you very much.
Thank you.
Maybe you augmented with the synchrony.
Yeah.
On the right ventricle?
Perhaps.
This is yeah.
Yeah.
Could be.
Thank you.
Okay. Thank you very much.
Thank you.